Great, thank you very much. Hopefully you can hear me and see my first slide.
Yes, clearly.
Brilliant. Thank you for the invitation. My name's Simon Eccleshall. I work at the Norfolk and Norwich University Hospital in the UK. And thank you, Professor Shin, for the very nice introduction. So what I'm going to talk to you today is about the SELUTION drug-eluting balloon. Just wait for my laptop to catch up with the fact that I'm sharing so I can send my slides on. At some point it will start working. Come on. Ah, there we go. Now I've gone too far. Sorry. I think it's too early in the morning for my laptop. Right, there we go. Start again. I think there's a lag. My laptop is talking to you and all the way back to me rather than directly. And now I'm pressing too many buttons. It worked beautifully just now when we tested it. Maybe it has stage fright. Try that way. Yes. So what I'm talking to you about is the SELUTION sirolimus-eluting balloon. It's a beautiful piece of technology that uses micro-reservoirs with biodegradable polymer mixed in with sirolimus with the idea of giving controlled and sustained drug release, hopefully up to at least 90 days to cover the restenosis cascade that we start off when we do balloon angioplasty. And it uses cell-adherent technology, which is essentially a bit like a membrane that holds all of the micro-reservoirs of the polymer with the drug in to deliver it to the vessel wall, which allows a relatively low drug concentration on the balloon surface to be delivered. So, does it work? Well, the pharmacokinetics would suggest that at 90 days there is still sufficient sirolimus within the vessel wall. The first-in-man trial, which is a fairly standard approach to assessing such a technology, took 50 patients and 6 sites with angiographic outcomes as you would normally expect at 6 months, with clinical event rates as well. Over the whole cohort, which included de novo and ISR work, as you can see, they had 1 target lesion revascularization. And within the de novo subset, they had no clinical events with a good angiographic luminal maintenance, I would say, at 6 months. So moving on then to some slightly more real-world data. This was used by Florim Kikuli and his team in Switzerland. They've been running the SIRUT registry, which is a real-world registry of drug-coated balloons in their hands. Their early work with SELUTION used 78 patients. They were looking at very high complexity patients with lots of calcium, and this group uses a lot of what we call cut and crack with cutting balloon and then OPN balloons. So a very complex group of patients, and they got an impressive TLR rate despite dealing with such a high rate of calcification and complexity. So this brings us quite rapidly onto this SELUTION de novo study, which actually has completed a couple of months ago. This is a large non-inferiority study for target vessel failure, comparing SELUTION drug-eluting balloon in a systematic way with systematic drug-eluting stenting in de novo vessels only. 3,300 patients, over 50 sites across Europe and Asia. The primary endpoint was target vessel failure at 1 year. And again, we were looking at target vessel failure at 5 years, non-inferiority at both. And if we achieve non-inferiority at 5 years, then the study is powered for superiority as well. Fairly standard secondary endpoints, as you can see. The PIs are myself and Christian Spalding from Paris. One of the differences of this trial compared to a lot of the drug-eluting balloon RCTs that are already out there, and certainly some of the ones that are currently running, is that we've turned it a strategy trial rather than a device randomization trial. So a lot of the RCTs, such as, for example, basket small 2, mandated lesion preparation first and then randomisation to either, in that case, the sequent pleased by B. Braun paclitaxel balloon or a drug-eluting stent. Here what we wanted was a different approach to answer a slightly different question, which is if you decide up front that your strategy is drug-eluting balloons with a bailout stent, how do you do compared to the standard of care of still the majority of the world, which is stenting everything? So if the patients were suitable, and I'll come on to that on the next slide, at angiography you have to decide, will everything be treatable with a balloon in your hands, or will everything be treatable with a stent in your hands? And if the answer is yes to both of those, then they're randomised. They then stay in that arm, but obviously in the balloon arm, if you need to bail out a lesion, then you bail out with a stent, but the rest of the lesions remain within the balloon arm. So those are the PIs, those are the numbers, and that's the endpoints again, as I mentioned earlier. So the inclusion criteria are basically any native vessel lesions that you would like to treat, with the exclusion of left main stems, CTOs, in-stent restenosis. We also excluded STEMIs, or very unstable non-STEMI patients. We also didn't want previous PCI in a target vessel because we thought that would confound the endpoints we were looking for, and we, for safety reasons, decided to exclude any previous PCI in the preceding 30 days. This is particularly relevant in countries like the UK, where we do obviously primary angioplasty, but then a lot of staged revascularization shortly afterwards. So the procedure was mandatory optimal lesion preparation in the balloon arm as per the third DEB consensus group. Intravascular imaging and physiology was optional, and after full lesion preparation, a drug-eluting stent could be deployed for a vessel-threatening dissection or too much recoil as estimated by the operator, or suboptimal physiology, but imaging and physiology was certainly not mandated. So what we wanted to also look at was, before we'd even finished the trial really, whether we were actually a truly all-comers study. Did the PCI techniques change over time in the balloon arm, and is there a learning curve? So we've looked at the first 1,000 patients in the DEB arm already. This has been presented firstly at PCR in May of this year. So we defined early as the first 20 patients enrolled in the balloon arm from any centre, and late were all the subsequent patients from that same centre, to see if there was any change in how we were operating. So those were the numbers of patients, and they rather fortuitously fell at around 50% in each arm. The baseline characteristics were pretty much unchanged throughout, which is promising. The baseline angiographic characteristics, the things of note would be around 60% of all the patients enrolled in the balloon arm were large vessel, as defined as 3 millimetres or greater. So hopefully it does represent a fairly all-comers trial, and you can see that the number of LAD lesions is a high percentage as well. What we found quite interesting was that over time there were more type C lesions, more calcification, more bifurcations, more multi-vessel procedures and staging, suggesting to us that our operators were becoming increasingly comfortable with a DEB approach and were taking on more complex patients. Target lesion preparation didn't really change over time, and compared to other recent RCTs of drug-eluting balloons, our cutting and scoring rate in particular was quite low. I was a bit surprised at this. Certainly in our centre it would be over 50% of all our DEB cases. Calcium modification was very low, and imaging and physiology similarly, quite small numbers. So we would say probably across the world that this is fairly real world as to what adjunctive therapies and modalities that operators will have at their access to. So what did we find? Well, at the beginning, we were bailing out overall at around 20%. The majority just was after lesion preparation, which is obviously where you would want to bail out, but about 9% was after balloons, whereas later on, the bailout rate overall dropped. The majority of it was still after lesion preparation and much less after use of the balloon, which is obviously the right thing to do. And where do we think that this fits? So the reasons for bailing out would be failed lesion preparation, which is where you should be bailing out for a suboptimal result or an unsafe result. And I think early on in a learning curve, operator inexperience will force people to put more stents in, either because they're not used to leaving dissections or just they have more discomfort at the idea of leaving non-stent-like results. The time you don't really want to be bailing out much is after DEB, which really would be late or missed lesion preparation failure, I would suggest, is quite often the case. Perhaps we need to wait longer or take a second view, for example. DEB trauma is very rare, particularly if you only use the balloon to deliver the drug, so do it very gently at very low pressures. And again, I think operator experience kicks in here a little bit in that people will DEB a very proximal LAD, for example, and then wish actually that they'd just put a stent in, so they go and put a stent in anyway. So hopefully what we've shown here is that from those sites that were enrolling at the time, lesion preparation was systematic. The technique for lesion preparation didn't particularly change over time, and that bailout stenting decreased with the learning curve. And we will hopefully be presenting the full study results at TCT next year, which will be the 1-year data. So what else is SELUTION doing? So in the US, they have a number of trials. The in-stent restenosis trial, which is complete. They have a de novo trial as well, which is a small vessel trial, and then they have peripheral work going on. The in-stent restenosis trial has completed as well. It was the SELUTION balloon against standard of care, which in the US is either drug-eluting stent or balloon angioplasty, and they capped the number that could have balloon-only angioplasty. As you may well know, the agent from Boston got in with a agent balloon against balloon-only angioplasty in-stent restenosis trial. Their de novo study is similar to the larger de novo study, but only in small vessels, in that they also have strategy randomization rather than device. So it's randomization before lesion preparation. Here's an example of a case that we did very recently. As you can see, the culprit lesion here is an ostial circumflex, but there's also a mid-LAD lesion. This is an ACS case. So we were planning full revascularization here if we can. The thing that's probably the most difficult for this case is those two bifurcations, I would term them. You've got a 001 with the ostial circumflex, and then you have a 111 of the proximal circumflex, including that very high obtuse marginal branch. So I play the game in my mind of how would I fit stents into that, and I think fitting stents into that would be very difficult. But if you have a balloon-only approach, the majority of the time you can make things much simpler for yourself. So here we are with 3 wires, one to keep the guide out of the left anterior descending artery to give us the space to get at the circumflex and the OM. We've gone with a 2.5mm scoring NSE alpha. After the first inflations, it looks a fairly underwhelming result. So we've gone higher pressure, longer inflations, merely with the same NSE alpha. And you can see on the right now that the ostium of the circumflex and the obtuse marginal branch have all improved. And we've only ballooned on that one wire into the distal circumflex. So we run a checklist for our DCB work, talk about lesion prep, giving lots of nitrates, making sure the vessel's big enough, that we've got rid of the recoil and that everything is deliverable. From the safety point of view, with obviously the most important thing, which is the patient is well and that they have no symptoms and the ECG is good. And then angiographically, we're looking for TIMI3 flow. You're allowed a little bit of luminal compromise by way of recoil, but you particularly don't want it to be progressive, which would be suggestive of intramural hematoma. You want to see any obvious vessel-threatening dissection, such as a very large spiral dissection. And you're looking for contrast that hangs up or stays in the vessel wall in particular after all the contrast is cleared. So you can see our shot on the right, we're waiting until all the contrast is completely cleared. So that's a very safe result. And then the last bit of the checklist is making sure you're using the right DCB by way of 1-to-1 compared to your lesion preparation balloon, which will be 1-to-1 angiographically with the vessel. It needs to be the same diameter, a little bit longer, and then you need to know, obviously, the transit time, i.e. from when it enters the sheath to when you start inflating it, and then the delivery time, which is how long it takes to deliver the balloon. And with solution, it's 2 minutes transit time and a minimum of 30 seconds delivery time. So DCB time, there's the balloon being used. There's the acute result. Again, if you run the same checklist, that's a safe result. You may have remembered we haven't finished yet. Here's the NSE alpha in the LAD. There's a beautiful intimal tear, a very safe dissection in the mid-LAD. We run our checklist again. We're very happy with that result. There's the balloon. And then again, we're just checking that nothing has changed. And if we've been very careful with our DEB delivery at very low pressure just to deliver the drug, we should be fine. So we've taken that very complicated two bifurcations from that to that using 3 wires, which is probably the most complicated bit, 1 scoring balloon only and 1 DEB only. So the conclusion from that case would be a very simple solution to a complex case, and that DCB and the newer DEB only approach simplifies both lesions for us as well as patients, and then we rely on vessel healing to restore our normal vasomotor function. So hopefully I've persuaded you that the solution balloon is a new balloon with a very clever way of delivering sirolimus, which up until now has, for the last decade, I think, has escaped industry as a way of helping us approach our patients with a new sirolimus delivery system. I've told you about our solution de novo study, which is already completed, and we're hoping to present at TCT next year. I've shown you the preliminary analysis suggesting, as we already know, that there is a learning curve, and hopefully that I've also persuaded you that it's the nearest thing we could get to an all-comers study for such a large trial. And I think if this, along with other studies such as the reverse study, which is running very successfully in your side of the world, we will be changing the way that angioplasty is performed for the better. Thank you very much.
Thank you very much for your valuable data and so beautiful case, true bifurcation lesion, left main. And
thank you.
And in Korea, and we don't have any sirolimus coated balloon yet so far. Okay. So your data is so interesting, and we have 9 panels. So maybe we have some discussion.
Sure.
Thank you for your very interesting and educative presentation. Thank you. In the DS era, sirolimus eluting stent was better than paclitaxel stent. So sirolimus was very familiar with to the interventional cardiologist. However, in case of the drug eluting balloon, the paclitaxel was used at first. The sirolimus eluting balloon appeared a little bit later in the market or clinical field. What is the main reason for the late appearance at the sirolimus eluting balloon in the clinical field for the manufacturing or development? And second one is, what is advantage of the sirolimus eluting balloon over paclitaxel eluting balloon?
Ooh, that's a lot of questions all in one go. Okay, so I will work with them backwards, if I may. So your last question was, what would be the advantages of sirolimus over paclitaxel? Well, we don't know the answer to that yet. Currently, we're looking to see whether sirolimus balloons are as good as stents even, and I think that would be the best place to start with expanding the DEB concept. But the potential advantages, one that I think now is fairly widely accepted already, is with all of the sirolimus balloons, they are more deliverable than generally most of the paclitaxel balloons. And I think that's to do with the type of excipient and the type of formulation of the paclitaxel drug, in that anybody that uses them knows that they are a little bit sticky and a little bit more difficult to deliver than, for example, a normal balloon, and sometimes, surprisingly, won't deliver when a stent will deliver. All the sirolimus balloons seem to be much more deliverable, and certainly the one that we've used so far, SELUTION, is significantly more deliverable than our standard paclitaxel balloons. So that's the first advantage. The second advantage is a theoretical one, really, which would be, obviously there were concerns on stents about the difference between paclitaxel and sirolimus, and that therefore acts as a barrier, I think, for people using paclitaxel balloons. So if sirolimus could take away some of those barriers by, for example, showing as good or even better results than paclitaxel balloons, because of the fact that paclitaxel is possibly causing some damage or some cytotoxicity or some inflammation that the sirolimus balloons aren't, then perhaps we could improve on what is already a very good technology with the paclitaxel balloons that work. So that's the theory behind it. I think in practice, the third thing that would be really good if sirolimus balloons work would be that we are just spreading the DEB concepts to an ever wider audience, which will benefit all our patients if they don't have anything left behind, particularly full metal jackets. Your other question was, why is it taken so long? I think the reason why it's taken so long is it was paclitaxel was very easy to deliver to the vessel wall because of its lipophilicity. And there are a number of different ways with different people that have worked out how to deliver it rapidly. And probably the best known would be the B. Braun Sequent Please, which uses iopramide, and it's shown that the drug gets to the wall very quickly. And it would be fair to say that a lot of industry have now spent about a decade trying to work out how to deliver sirolimus in a way that it would actually stay in the vessel wall long enough. And a bit like with paclitaxel balloons, there are some that work, some that don't, and the ones that don't have already, to some degree, been taken off the shelves of cath labs and are disappearing from the market. I think the same will happen with sirolimus balloons because it is very product specific. And actually, I think it's more difficult to design the technology to deliver the sirolimus for long enough for it to be in the wall to have its effect on the restenosis cascade. I think that was all of your questions. Correct me if I've missed one.
Thank you. Let's get just I have a question. Is this use cell adherence technology or CAT or the micro reservoir effect? What is the main effect? Is it more the drug permit to the tissue or the long time in the tissue, or what mechanism is the main mechanism?
So that's a great question. It's essentially what they did was they worked out a way of delivering the sort of polymer that we know on a drug-eluting stent will give a controlled, sustained release of sirolimus. They then worked out a way of putting the sirolimus into that polymer, but not having that polymer on a stent, so they're just delivering the polymer to the vessel wall. And the cap membrane is the system that keeps it on the balloon and then delivers the polymer to the wall. The membrane itself is virtually not really a membrane in that you can deliver it across a bifurcation and it just disappears. But what it's doing is it's holding that polymer onto the wall until the polymer is embedded enough that it will stay there and gently elute the sirolimus for you. So I think the reason why it's called a DEB specifically is it's eluting sirolimus in the vessel wall for a sustained period of time. Whereas, for example, most of the paclitaxel balloons out there basically just use something else, an excipient, to get the paclitaxel into the vessel wall quickly. And then because it's so lipophilic, it's taken up into the vessel wall and stays in there in its crystalline form for months afterwards. I hope I've answered that question for you.
Dr. Simon, do you think that it's critical to calcium modification with the cutting or the squaring before DEB in terms of the better tissue penetration?
So I think it's vitally important that we do really good lesion preparation with calcium, because we know already that calcium is a marker of higher TLF rates in drug-eluting stents, and there's at least one DEB publication suggesting the same, unsurprisingly, with drug-coated balloons. We've looked at that within our own cohort, and we found again that calcium makes it more difficult for stents, but also more difficult for drug-coated balloons. It does work, but never quite as well, I think, is the answer. Why should we use cutting and scoring balloons? I think the reasons why we should use them that I don't think are in any question would be you get better lumen gain if you use cutting or scoring balloons, particularly in calcified lesions. And also, if you're going to get dissections, and that's obviously what we're doing with angioplasty all the time, you get much more controlled linear dissections that still allow you to go down the route of a DEB-only approach rather than having to bail out to a stent. There is definitely a theoretical advantage of lots of cutting or scoring planes possibly allowing more drug into the vessel wall, but I think in the de novo setting that really hasn't yet been shown to be the case. But certainly, yes, calcium is more difficult for us.
Okay, Simon, we don't have enough time, sorry.
Okay.
Thank you very much for your excellent
Pleasure.
presentation in the early morning today. And
It is, yeah.
okay. I hope the SELUTION study has a great success. Thanks again.
Thank you. Thank you. Lovely to see you all. Good luck with your
Thank
trials.
you.